Like I said, we're going over co-occurring psychiatric disorders and substance use disorders. This is a very common phenomenon and something that we should expect, as we'll talk about here in a bit. That will be one of my overarching themes for today, is that in general, when we're seeing patients with any mental illness or with substance use disorders, we should certainly be screening for, looking for the other diagnoses as co-occurring. No financial conflicts to disclose. This is the first slide of every single presentation that I give. For any lecture, doesn't matter if it's our didactics here internally with the program or any larger gatherings. I think this is kind of the thing that guides our decisions, how we treat people, and all of our management. Patients are people, and people have value, and that value is intrinsic to being human. It is not dependent upon their perceived societal benefit. It is not dependent upon any substances they may or may not use. People's value comes from being human, and that is something that we really stand by here. And I am not concerned that all of you don't already know that, but I still put it at the beginning of my presentation. We will get a little bit of here down at the bottom where it says special population example. That's actually where I've added the cases there. The rest of the outline is all the same. This epidemiology comes from the National Survey on Drug Use and Health. These are the 2023 numbers. And as I said, the overarching theme is that co-occurring diagnoses should be our expectation, and not an exception. Now, if you look at the epidemiology, yes, all of those numbers are less than 50%. So we certainly can't honestly say it is more common than not, but it is certainly common. From the 2023 survey, about 17.1% of respondents had past year substance use disorder. Just a bit over that, so a little shy of 23% had any mental illness. And then of the patients with any mental illness, just over a third of those, 35%, had a co-occurring substance use disorder. And in patients with a substance use disorder diagnosis, 44% of those had a co-occurring any mental diagnosis. And so it is very, very common. I suspect that those of us who work in the realm of substance use disorders treatment, we see this, we know this. I think where this a lot of times is perhaps more needed is in the primary care setting, where people are seeing anxiety, depression, some PTSD, and are maybe less aware of how common this is. We'll talk about diagnosing a little bit. So there are some considerations in diagnosing. There are specific DSM-5 criteria when we're looking at diagnosing what is substance induced, what is not. But what I really want to talk more about is kind of the difficulties of diagnosing and what's important. So the chronology of symptoms, and how their mental health symptoms have lined up with their use is very important. Symptoms during their use and abstinence, and then has it responded? There are a lot of different things that can look like mental illness that are actually substance use disorder. So this chart here, the I and the W is intoxication and withdrawal. And so you see really significant overlap here of how various substances, whether it's in the intoxicated state or the withdrawal, look like mental illness. So it is very common, for example, for people to come here carrying a diagnosis of bipolar disorder. And when you get a bit more history, well, I was diagnosed with bipolar when I was 23. I started using meth consistently at age 19, and they've really never had any periods of abstinence prior to their diagnosis. So it can cause a lot of confusion, and it can be very hard to tease out sort of what's the driver. There are a lot of DSM recognized substance-induced mood disorders, and they can be very specific. So some of the more common ones that we will see is substance or medication-induced depressive disorder or anxiety disorders. Those are very, very common. But we also can sometimes see persisting amnestic disorders and persisting perception disorders with hallucinogens that are somewhat less common. But this is really just to point out there are a wide variety of mood disorders that can be substance induced. And this is direct effect of substance. But there's also the way that substance use changes how people behave outside of substance use. And so a lot of times, for example, substance-induced depressive disorder in someone with an alcohol use disorder. Alcohol is a depressant, and so there can be an alcohol-induced depressive disorder, but also the effects of a substance use disorder on someone's life can make them more prone, right, to depressive thought, depressive mood. It can cause sleep disturbance, right? So a lot of these, it's not only the substance itself, but it's also the effect of the substance. And so there's a lot of nuance in diagnosis here, which can make it somewhat difficult. So here are some of the criteria for substance-induced mood disorders. I'm not going to read over all these. The thing that I want to really point out is that kind of that third primary bullet, the second sub-bullet there, the full mental disorder persisted for at least 1 month after cessation of acute withdrawal or intoxication or taking the medication. So that's the DSM criteria is 1 month of abstinence and persistent symptoms. Clinically, depending on how long someone has been using something, what the substance is, what their metabolism is like, what other sort of neurologic vulnerability they have. Sometimes a month is a bit on the shorter side. And so there can be persistent effects from some things that will last longer than that. And so even a month of abstinence is not necessarily clinically enough to make you feel very, very confident in the diagnosis of a standalone mental disorder. I don't expect you to be able to read it. This is a small part of an algorithm for treating ADD within the context of a co-occurring substance use disorder. And you see a whole lot of branch points. And like I said, this is a small section of the algorithm. So this is really just to illustrate there's a lot of nuance, there is a lot of complexity. And so it is very rarely as simple as patient brought into the ED with a STEMI. Here's our protocol. These are the things that are going to happen, right? Doesn't matter pretty much what ED you go into in the country, right? Here's the protocol. Here's what we're going to do. This is our door to balloon time we're shooting for. Everything is kind of mapped out ahead of time as soon as you have the diagnosis. With most of what we do, that's not the case. And it's certainly not the case here with co-occurring disorders. There are some common misconceptions that people have. One is that if someone has a substance use disorder and we treat a co-occurring mental health disorder, well, it's not going to work because they're still using whatever it is they're using. And on the flip side, people often think, well, if they, just because we treat whatever the underlying depression, the underlying anxiety, well, they still have a substance use disorder. That's not going to impact their substance use disorder. And then also that patients with substance use disorder are going to divert or misuse their medications. So we'll address those. We should be treating any disorders that we encounter, right? So if there are two or more that are present concurrently, we should treat them both. We oftentimes have some hesitation toward using controlled substances to treat a co-occurring mental health disorder. And certainly due diligence should be done, but it's not necessarily a contraindication. You may be able to get a 2-for-1 benefit, but most of the medications that we would use that might get, that 2-for-1 benefit, it's really off-label use. So I'm going to breeze over this so we can get to the cases. These are just some study results for co-treatment. So what I would like to show really in this is that this top is on treatment of treating anxiety disorders, depression, in the context of a co-occurring substance use disorder. And then the bottom one is treatment outcomes in, well, here, ADHD. So ADD, hyperactive type. And it works both ways, right? So we have good evidence that shows that when we have co-occurring disorders, yes, the mental illness that is not substance use related can improve with treatment, even with ongoing substance use. And if we are to treat a substance use disorder, they can get benefit even if they have a co-occurring mental health disorder. Now, certainly either of those things are going to present barriers, but if we have multiple issues, we should treat them. So we've got one good medication that is FDA approved for a mental health disorder and a substance use disorder, which is bupropion. And so we can use that for major depressive disorder. We can use that for seasonal affective disorder, and we use it for smoking cessation as well. But the list of things that we use that are more off-label is a bit longer. And so these are medications that are FDA approved either to treat a mental health disorder or a substance use disorder, but we may have some off-label benefit for using for the other thing as well. This is a study on diversion risk of prescription stimulants. And as you may expect, we see that peak there sort of in the early 20s. But what I would like to note is that's 10% is the peak, which is still relatively low. And so this really just serves to challenge the notion that patients who have a substance use disorder will divert or misuse their medications. That is, I think if that is something we believe, we're doing our patients an injustice. There is absolutely a risk, and it's a risk that is, we're all aware of, and it's well documented. There is a risk of diversion with any controlled medication, but fear of that risk should not prevent us from treating people appropriately. You compare that to antibiotics. There's some pretty, I think, pretty intriguing studies out there on antibiotic misuse. There was one in particular that was at a university health clinic. So similar population here, right? So you're looking at 10% is the peak of people who are misusing or diverting stimulants. So similar population, right? At a university health clinic, of those who self-treated with antibiotics prior. So this is, we get this all the time, particularly in primary care. Somebody comes in, oh, my sinuses have been hurting. I've had this cough. I'm feeling crummy. And so I've taken 2 days of antibiotics, and I came here, hoping you would finish the course. And so sort of above and beyond any question of, well, or would antibiotics have been indicated in the first place? 43% of those were obtained from a leftover prescription, um, which obviously is a very common thing, but also that means that 57% of them were not. And so they got those antibiotics from somewhere, right? So they were using other people's medications. A lot of times, when we look at good antibiotic stewardship, this is one of the reasons why we tell people, even after you start feeling better, keep taking your antibiotics. But I've had people come in who say, well, my dog was on antibiotics for something, so I've been talking, and I only gave the antibiotics for a couple of days, so I've been taking my dog's antibiotics. Antibiotic misuse very, very high, but we don't seem to get quite as wrapped up in fear of antibiotic misuse as we do fear of controlled substances. But that's just to note that it's really, really high. And that so the idea that I'm going to write this prescription and they're not going to do exactly what I want them to do with it, that's really the case for all populations and most medications. That is absolutely not something that is specific to patients with a substance use disorder, and it's absolutely not something that is specific to controlled substances. So I've got two cases, and they are very different. One of them is to show how difficult it can be and how complex and at times frustrating it can be when someone has a co-occurring disorder. And the other is to show how sometimes easy it can be, right? I think most of our co-occurring diagnoses tend to fall more in line with this first case than with the second, but certainly you'll see both. So we have a visit in December of 2020. This was a 48-year-old lady who had multiple substance use disorders along with hypertension and COPD, and she presented for intake. She'd been seen by a lot of OBOTs in the area in the years prior, kind of off and on, discontinued treatment with those for one reason or another. She did have a lot of transportation issues, so sometimes it was for multiple no-shows. Her most recent, they had tapered her buprenorphine because she was positive for methamphetamine and benzos on her UDS. And when they tapered her down, she was not seeking a taper. That was just the clinic policy. When they tapered her down, that was ineffective to control her opioid cravings. And so instead of having two unstable substance use disorders, now she has three unstable substance use disorders. She started buying additional buprenorphine off the street, and eventually just came to a place where she didn't feel like it was a great therapeutic relationship. And so she ended up coming to our on Vraylar, 1.5 milligrams a day, but she had been out for a while. So she had stopped going to her previous clinic, and it had been a bit since she had been there. And so she had run out of her Vraylar. She had run out of a couple of her other medications. She had run out of her buprenorphine as well. She reported meth use multiple times a week, primarily smoking it, would occasionally snort, no current IV use, and then reported primarily alprazolam or clonazepam, benzodiazepines from, what we call it from the street, but really it was from family members. And that is how she presented December of 2020. So Here are her initial labs and mental status exam. She was positive for the things we expected her to be positive for. Relatively unremarkable lab. She was chlamydia positive and her glucose was just touch high, although I would be somewhat surprised if those were fasting labs. So, and then mental status exam, as you see, somewhat disheveled, mumbling, not very direct in her line of thought and answers. And did not seem to be responding to any internal stimuli, just very sort of disorganized, poor eye contact. Any thoughts, any next steps that anybody would take or additional information you would like? Can everybody still hear me? My internet is sketchy.
We can hear you. You froze up once, Caleb, but
Okay.
but you're good right now.
Okay. Just bang on the wall if I cut out.
I thought about it.
Okay. All right. So the next handful of visits, we got a bit more information. She continued without her VRAYLAR, so she was looking to establish with a different PCP as well. And so this process of obtaining records, making those decisions about what are we prescribing, what are you looking to get from someone else. So she had gone several visits without her VRAYLAR. Her only diagnosis on her chart was anxiety. Again, she did self-report a history of bipolar versus schizophrenia initially, and that was primarily in the setting of stimulant use. But her primary ongoing concern was anxiety, and so she noted that was the trigger for her ongoing benzodiazepine use, as well as prescribed hydroxyzine. She gave a bit more information in bits and pieces as far as her mental health and trauma history. But as she came over those initial couple months, she started having more paranoid and disorganized behavior. But she also continued to report meth use and was consistently positive as well. So a lot of this information would come in discussing her anxiety. And so with the continued benzodiazepine use, she said, well, I'm very anxious. I've got a lot going on. And a lot of her anxiety are with her interpersonal relationships, which is very common. And so she was accusing multiple friends and family of stealing from her, of breaking her things, which are, again, very common and believable things. And that's one of the difficulties of making confident diagnosis with, ongoing use, or even without ongoing use, right? When people who have a delusional disorder oftentimes can be very, very believable. And the things that they will bring to you with concern is things that are kind of right on the edge of, I could see that being the truth, right? Especially our patients who are in unstable living situations, right? People are stealing my things, people are messing with my things. Those things happen, right? But as we went on with this patient, her accusations started to become more bizarre. So it wasn't, well, somebody stole my wallet. It was my neighbor stole all my pants and undid the seams of them and then sewed them back wrong. Right? There are people hiding under the bed. I know they're there. I look under there and there's nobody there, but I know they're there. Right? So at this point, she was not having much in the way of auditory visual hallucinations, right? It was primarily delusional, although again, with what exactly it was that she was experiencing and seeing. For example, she would take pictures of her clothes and she'd say, you see here the seam that's done wrong, right? So she was not, in terms of her sensory experience, she was not experiencing the world as the rest of us were. But it was the paranoid beliefs that were primarily driving that. So she had diagnoses of PTSD and bipolar disorder were initially added to her list at this point. And then over the next 6 months, things continued kind of the same. She was started back on Vraylar. It was back at the 1.5 milligram dose at this point. Meth and benzo use were lessening over her initial 12 to 15 drug screens. She was probably negative for meth 3 or 4 times, probably negative for benzos about 7 or 8 times. And so that had decreased relatively significantly. But she was still always concerned about people are messing with my stuff. There were a few specific people that she would consistently complain about. Daughter's boyfriend was one. She didn't get along. Well, I don't like him. He's always making up lies about me. He's stealing my things. Her Vraylar was increased to 3 milligrams, but it was somewhat inconsistent, even at that point. But things were about the same. She continued to have a lot of paranoia, but nothing that was overly bizarre. Mood was generally poor, eye contact typically poor. You go into the room and talk to her and she's, playing games on her phone the whole time, just wouldn't even look up the whole time. So poor eye contact, and still somewhat disorganized. And it went this way for a very long time, or what felt like a very long time, right? Next couple years, still mostly using meth, but sometimes not, and mostly having paranoid delusions, but sometimes not. Nothing large changed in terms of her management. We had offered her some long-acting injectable antipsychotics, but she was not ready for that at that point. These paranoid delusions were nothing where we felt like she was unsafe. And she was having, at this point, inconsistent methamphetamine use. The benzodiazepine use became far less frequent. So sometimes she would have some stretches where she would test meth negative, maybe 3 or 4 visits in a row. But there was still some waxing and waning of her paranoid symptoms. And it was never really long enough to feel very confident in making a diagnosis of a standalone, not substance-induced mental illness. So we continue to offer her higher level of care, primarily for her ongoing meth use, but she was not ready for that either. And that was about 2.5 years. And then in about September of 2023, she finally agreed to going inpatient for substance use disorder specifically. So we got her down to a program in Knoxville. She did a 30-day program, then she did a PHP, and then she entered into recovery housing. So it was several months. We did a couple telehealths with her during that time. She reported no meth use, and she was, she was being tested regularly by her recovery housing as well. But she went through several roommates during her recovery housing, and during her inpatient treatment and her partial hospitalization, she was not responsible for dosing of her own medication. Once she moved into the recovery housing, she was responsible for dosing her own medication. And so use became, well, not use, use of her medication became more inconsistent during that time. And so she did have a good period of about 4 months where she was not using any methamphetamine, not using any benzodiazepines. But then she began to have more paranoia. She did have several roommates because of interpersonal conflict, and it was a lot of the same things we had heard from her for several years. Um, they're stealing my things and nobody wants to do anything about it. And again, it's at face value things that are absolutely believable. And it's not until you kind of get more depth there in what's going on that you would start to see some of the more bizarre accusations. So because of this, she said, "I'm tired of it, don't like living here, I'm moving back to Johnson City." So she moved back, lived with her grandmother. Partially, she bounces around a bit, and continued back with her meth use and occasional benzodiazepine use. So this has been, at this point, a little over a year since she moved back. And since then, her use has actually been more frequent than it was. A lot of this has to do with living situation. She had a somewhat more stable living situation prior. And since she has moved back to Johnson City, the living situation has been a bit more unstable. Um, she's gone right back to associating with the people that she was using with. So since that time, we have switched her to long-acting injectable paliperidone, titrated her dose up, and her mood has drastically improved. She's spending a lot more time with grandkids, spending time, with her daughter. Um, and the delusions have improved. She's absolutely still has some paranoid behavior. She is very, very slow to trust, um, which I think would be reasonable with or without her delusional disorder. She's e experienced life in such a way that being slow to trust is, I think, an acceptable response to what she's been through in life. Um, but the more bizarre accusations have mostly gone away, and this is despite, before she was having probably a quarter to a third of her urine results were negative for meth and or benzos, and she's only had one meth negative urine in the past year. So from a substance use standpoint, which is this is not the primary point of this case, but I think a worthy side quest. Abstinence is not our only goal when we're looking at recovery, right? So if you look at this patient on paper or in the chart, and you look at the trend of meth positive, meth negative urines, she's gotten worse, right? She was having somewhat consistent meth negative urines, and now she's gone to none or one in the past year. But when you meet with this person in person and you get the collateral information from family and you look at her functioning in her day-to-day life, she is drastically improved. And so this is not, that abstinence is not really the only marker of how well somebody is doing. And so for her, the kind of key takeaway here is I am still not 100% sure, what her underlying diagnosis is. She obviously had 4 months of abstinence and was having symptoms at that point. But then as soon as she came back, the first time she came back and visited with us, she was meth positive again. So I was not able to sit down and get a good in-depth evaluation of her at that time when she was in Knoxville and 4 months abstinent. And so that muddies the water. I um, have added a diagnosis of delusional disorder for her. Um, I do. It has been relatively clear over the years that when she is using meth, a lot of that gets worse. But that in and of itself doesn't mean that it is only a substance-induced disorder. So this is really to highlight some of the complexity and um, and how difficult it can be, not only to manage these, but also to be very confident in diagnosis, right? You get that DSM-5, well, you need a month of abstinence, but um, sometimes even with that, you can have some lingering effects. I for her, she's had enough time. I do feel relatively confident she has a mental illness that is not driven by her substance use, and we are treating her, and the injectable paliperidone has helped with that quite a bit. Second case is a bit more straightforward. This was a 29-year-old lady who had inattentive type ADD, opioid use disorder that was long-standing, a stimulant use disorder, for use that had been very brief prior to finding out she was pregnant. She presented as a transfer to our clinic. She had been seeing an OB provider, and then when she was 6 months postpartum, she transferred to us. She was on 6 milligrams of buprenorphine naloxone, bupropion 300 milligrams daily. That was primarily, she does have tobacco use disorder, but the listed reason for this was primarily trying to help with her ADD symptoms. And then she was on Sprintec. This is her substance use history. This is part of our intake. We get this substance use timeline, kind of goes birth to um, whatever age they are now. And anytime you see here, like up on caffeine and nicotine, you see those solid lines, that's consistent use. And then you'll see, like in the stimulant or sedative hypnotic, you'll see kind of those dashed lines, that's intermittent use. And what's really helpful, I think, the way that we do this with getting this information is I didn't get a screen clip of it below because there was some identifying information in there, but you see that a lot of you see various ages marked on here, and the way that we do this is it's a part of the comprehensive behavioral health intake. You see very often how this use history lines up with significant life events. We'll see very, very often, the close friend or family member died, parents divorce, someone in the house was incarcerated, and a lot of times you can see how that lines up with use. But this patient's substance use history, nicotine, longstanding, very brief non-prescribed opioid, and then she has been on buprenorphine for just over 10 years and had one short but significant return to use during that time frame, which was a couple years before presentation. That was also when she started using methamphetamine briefly, stopped both of those and got back on buprenorphine, stopped using the meth when she found out she was pregnant. She was late to prenatal care, got back on buprenorphine, did well, has not had any return to use since finding out she was pregnant of any non-prescribed substances. Yeah, she reported being diagnosed with ADD at age 11. They had her on methylphenidate for several years. Interestingly, she won a scholarship to be on a jump rope team. So she spent a year in Germany competing in the jump rope. So she did a foreign exchange there. And then when she got back upon follow-up, they determined, I don't really think you have ADD. I think this is more so anxiety. So they stopped her methylphenidate, switched her to an SSRI. She did not do very well with that change. She reported having more trouble in school. Although certainly there are some confounders here, right? Going abroad for a year and then coming back. But she, um, she said, well, I don't want to blame it all on the medicine, but there was a distinct difference in how I felt with that switch. She felt very disinhibited on SSRIs, and she reported that she felt like maybe that had some, at least small part to play in some of her early substance use, more mood disorders. And then she had some college substance use interfered with her studies some, but she also reported ongoing concentration issues, trouble completing tasks, working on schoolwork. So, any thoughts or next steps here from anyone? Or anything else you want to know?
Symptoms were present in her childhood as well.
Yes, she was diagnosed at age 11
Okay.
and was on a stimulant for about 4 or 5 years. So, we spent a little bit of time confirming that diagnosis, and started her on atomoxetine initially, which is as an aside, typically what I do, I will typically start with a non-stimulant once the once the diagnosis has been confirmed. That is just my personal practice. We have other physicians here who go straight to a stimulant. Again, this is not coming into the hospital with a STEMI and we know exactly what we're going to do for you. I could make the argument for why I do it, why I do, or how I do. I could also make the argument for why I do it is wrong. That's kind of the way that our work works oftentimes. But I do typically start with the non-stimulant first, although I'm rarely surprised if it doesn't work. She didn't report any side effects, but she also didn't report any improvement. So we increased her dose to 80 milligrams. She said at that dose, she had intolerable side effects, mood swings primarily, so she stopped. We started her on extended release methylphenidate, 10 milligrams a day. She got better, but then she noted that it's really good for 2 or 3 hours after I take it, and then it seems to not be so good. Although she was taking it at all kind of different times throughout the day, depending on her work schedule. So we talked about the potential of switching to twice daily dosing versus increasing the dose, taking more consistently. So we went up to 20 milligrams once daily, talked about more consistent timing, and then we had decreased her bupropion down. I do not recall what her side effects were. She had some side effects that she didn't love, and she didn't seem to be getting much smoking cessation benefit from it. And so we had stopped that, and that's where she's been since that time. She's doing well. We've had no more dosing increases. 20 milligrams is on the lower side of what I typically expect most people are going to need. That's in accordance with what data we do have, seems to point to patients with co-occurring substance use disorders needing higher doses of medications for adequate treatment. This patient has done well on 20 milligrams. She has maintained on her 6 milligrams a day of buprenorphine. She's had no return to use of opioids or non-prescribed stimulants. She's been working the same job for a couple years. She's moved out of her mother's house, and she's contemplating her options. She wants to go back to school. She's very involved with, her kid is signed up for all kinds of, he's 2 at this point, signed up for all kinds of different classes. She gets him where he needs to be and really seems to be thriving with her current regimen. So that is an example of how easy it can sometimes be. And the reason that was easy is not because I did a great job, it was because I got lucky. And sometimes you get lucky with patients who do well with minimal interventions. I would argue that's probably not our typical experience, but so the take-home points are, if you're seeing someone with mental illness or substance use disorder, we should generally expect that they have a co-occurring disorder. Making a confident diagnosis can be difficult when the substance use is ongoing. Use your DSM-5 criteria for the diagnosis, but again, 1 month of abstinence is oftentimes not enough. It is enough to make the diagnosis. I would say it's often not enough for me to feel confident in that diagnosis. And then if they have more than one disorder occurring, you treat them both. And then do your due diligence, but having a use disorder is not necessarily a contraindication to treating with a controlled substance. That's all I got.
Muted. I got the camera, but not the microphone. Thank you. That was fantastic. I obviously am really slow and not so hot with all the little things you can do on Zoom. And when you said earlier in your presentation with the first patient, abstinence is not the end all be all. I can't remember exactly how you said it, but outcome. And I was trying to find the little hands put up like, that's right. I couldn't find them fast enough. It would have been really random by the time I found them. So, but that was an excellent point to make in a very complicated case. Yeah, and you did a great job of nutshelling it.
Okay.
Other comments or thoughts on these cases or similar experiences, the difficulty of navigating that co-occurring? What am I looking at? Is it an underlying psychiatric diagnosis? Is it substance induced? Does it matter? And I just need to treat it anyway. That's usually where I end up coming out. Like, I need to treat it anyway. Chicken or egg, it needs to be treated.
Yeah.
And another things that you mentioned that DSM-5 saying that after 1 month of the abstinence, you can make lots of those substances that we do know, like, for example, marijuana or a stimulant. Sometimes, even it's not in your system in a month. So if you've been a, regular user of the marijuana, sometimes it'll linger around more than 2-3 months in your system. So that would be another argument to say that that is not written on the stone. And you need to consider that some of those substances does not leave the body completely, and it does have some effect on the patient too.
Absolutely. Any other comments or thoughts on these cases? I think it's totally cool that last patient got to go to Germany on a jump rope team.
Yeah.
That's freaking awesome.
I probably that visit
Oh no, he froze. Should I go bang on the wall? He's back. I was gonna go bang on the wall, Caleb.
Yeah. And I wonder if he was in Germany, she was continuing the stimulant use, stimulant treatment. So I think
I believe she did. It was when she came back to the States that they had changed that.
Yeah, that's unfortunate that the treatment is going to stop and maybe, change the future, of the patient abruptly and causes lots of, headache for the patient. I mean, she's still young. She can pursue the future, but just looking at this picture, going back, that switch from the methylphenidate to the SSRI maybe really affected completely the future of the person.
Yeah.
Yeah, no pressure, anybody. Just don't screw anyone up, okay? Okay.
I just wanted to make a comment and say thank you. I appreciate both of those. I have some patients that relate to a little bit of each of them. The second one, especially though, because I have other nurse practitioners that have questioned and, can we do this? I follow forums on social media and they'll say, oh, we absolutely cannot do stimulants if they're being treated with buprenorphine. And I've had several successful people. I mean, it's not, I feel like we have to look at each patient and what's going on with them in that situation at that time. And I hate that people don't recognize that it's so important to maintain treatment for both mental health, whether it be with a stimulant or just mental health in general. With substance use disorders, we can't just treat one. We have to get a hold of both. So I appreciate this. I enjoyed hearing about these two people.
The other thing is, it varies somewhat state to state. There is at least some degree of evidence that prescription psychostimulants may be helpful in decreasing non-prescribed stimulant use. And so if you certainly in Tennessee, if you don't have a co-occurring ADD diagnosis, you're at the very least going to get some side-eye looks if you're treating someone with ongoing meth use with a stimulant. But I would argue that having the co-occurring diagnosis really gives you a very adequate and appropriate reason to treat. And then, the evidence base for psychostimulant use and decreasing meth use is about as good as it is for any other medicine, which is not to say it's great, but I mean, it's about the best thing we've got. So there could be some additional benefit there.
I think one of the important things to not lose sight of is because somebody has a substance use disorder, whether it's one that utilizes buprenorphine or any other controlled medication to treat, standard of care. Just because you have congestive heart failure and hypertension doesn't mean you're treated. I mean, there are different regimens that go together, but it's not like because you have this one thing, I can't treat the other thing. Or, oh my God, you have a stimulant use disorder and strep throat, and I can't give you antibiotics because you have a stimulant use disorder. Or like we really easily lose sight of the person. And to harken back to the very first slide that Caleb shared with us, patients are people and people have value, and we need to treat them as we would treat any person regardless. And I often see people treating individuals with substance use disorder who have pain, like acute pain, post-operative pain, differently. Like, well, we'll give you Tylenol and ibuprofen. I'm like, well, the person next door who had the same surgery and doesn't have that history of on their chart, they're getting Oxy. So what's the difference? Pain is pain. So keeping that in the forefront of your mind, I think everybody here does. And I appreciate each and every one of you and the hard work that you do, and just keep pushing forward. We're all trying to do the best thing for the people we see in front of us. And I kind of made a joke about, like, they switched her from her stimulant to an SSRI, like, no pressure, don't screw anybody up. But when we do make a mistake, catch it and correcting our course and making certain that we're getting our patients back on track. We all have a misstep every now and again, but I think the greatest misstep any of us could have, and I know none of us on this call do, is ignoring a diagnosis and not addressing it with standard evidence-based care. So again, I appreciate everybody here. We'll see you again in 2 weeks with another didactic, and then 2 weeks after that, cases to follow. And by the way, if I'm looking at my calendar right, we have 2 more sessions before we say hello summer break. So make certain to bring your friends when we get back together again, guys. Thank you.